Welcome to the deep dive. Today we're navigating a deeply sensitive but incredibly important area, suicidal thoughts and behaviors.
Yeah.
We've immersed ourselves in a pretty comprehensive chapter on this, and our goal is really to pull out the key insights to help you understand this complex part of the human experience.
It's vital information. Absolutely. And we want to present it in a way that's, informative but also manageable. We've looked at quite a range of material, everything from how professionals assess risk right through to, well, how we support those affected by suicide.
Right. So our mission for this deep dive is pretty straightforward.
Yeah.
Just extract the key understandings about suicide. We'll cover definitions, look at risk factors, discuss assessment, interventions, and also the impact it has.
Yeah, the ripple effects.
Exactly. On individuals, on communities. Okay, so let's start maybe by just getting clear on some key terms.
Absolutely. Clear definitions are, well, they're crucial here. Suicide, sometimes people say completed suicide. That's the act of intentionally ending one's own life. A suicide attempt, on the other hand, involves deliberate self-inflicted actions that could have been fatal, but, well, thankfully weren't.
Right.
And then there's suicidal ideation. That's the experience of having thoughts about taking your own life.
Got it. And we also came across physician-assisted suicide, PAS, and physician aid in dying, PAD. Can you maybe unpack those a bit? How do they differ from euthanasia?
Sure. So PAS or PAD, it's when a physician gives a terminally ill patient that means the medication to end their own life, but under very strict legal conditions.
Okay.
The key difference from euthanasia is about who actually administers the dose. With euthanasia, a doctor or someone else gives the medication. With PASPAD, the patient has to take it themselves. They keep control over that final decision if and when.
That makes sense. It's definitely an area with a lot of legal and ethical weight. What did the sources say about where things stand legally?
Well, as of mid-2019, in the U.S., 8 states plus D.C. had laws allowing PASPAD, often called death with dignity laws.
Right, like Oregon. Exactly. Oregon, California, Vermont, places like that. And there are usually strict rules, like you have to be a resident, 18 or older, terminally ill with, say, 6 months or less to live, and you need to make multiple requests, verbally and in writing.
Okay.
Internationally, you see PASPAD legalized in places like Canada and Switzerland, and then a smaller number, like Belgium and the Netherlands, actually permit euthanasia, too. It's, definitely controversial, often influenced by religious beliefs.
Okay, so that gives us a good foundation on the terms in that specific legal context. Let's dig into the prevalence now. How common is suicide and what factors increase the risk?
Globally, the figures are, well, they're quite stark. The World Health Organization estimates around 800,000 people die by suicide every year.
Wow.
Yeah, makes it a huge public health issue. And it's the second leading cause of death for young people aged 15 to 29.
Second.
It's staggering.
It is. And it's also a growing problem for people over 65.
Yeah.
And maybe not surprisingly, the single biggest predictor for a completed suicide in the future. It's having made a previous attempt.
That makes intuitive sense, yeah. But beyond that, what else contributes? Especially, when someone's in a crisis.
Well, the sources pointed out that certainly in many developed countries, suicides are often tied to impulsive decisions made during really stressful times.
Like what kind of stress?
Could be major money problems, financial difficulties, or the end of a significant relationship, or getting a diagnosis, maybe a worsening health condition.
Right.
We also learned that being part of a minority group can increase risk, possibly because of discrimination experienced by, say, refugees, indigenous peoples, the LGBTQ plus community, even people in prison. And tragically, just knowing someone who died by suicide also increases your own risk.
It's really striking how risk isn't uniform. What about differences between men and women or cultural factors?
Yeah, there's a noticeable pattern there. More men tend to die by suicide, and they often use methods that are, well, highly lethal, like firearms.
Right. Firearms for men, that's often cited.
Exactly. Whereas more women attempt suicide, and they frequently use methods like overdose.
Oh.
Culturally, methods can vary too. For example, in some Native American cultures, suicide by hanging has been reported as more common.
The idea of copycat suicides or suicide contagion, that also came up. That sounds really worrying.
It is. It's a serious concern. These clusters, or contagion, it's a recognized phenomenon. And the media, unfortunately, can sometimes play a role. The WHO actually has guidelines for reporters on how to cover suicide responsibly.
I remember hearing about that show, 13 Reasons Why.
Yes, that was mentioned specifically. Some mental health professionals reported seeing an uptick in suicidal thoughts and attempts among young people after it aired. It led to warnings for schools, for parents.
So a double-edged sword, maybe. Sparking conversation, but also potential risk.
Exactly. Some argued it opened up important discussions, but that potential for contagion is, well, it's a very real and significant issue.
The link between mental and physical health keeps coming up in our deep dives. How does that play out with suicide risk?
Oh, the data shows a very strong link. The CDC estimates a really significant chunk of people who die by suicide also have a physical health problem happening at the same time, or a history of problematic substance use, or a diagnosed mental health condition.
Right.
And for people dealing with severe pain or a really diminished quality of life because of illness, sadly, the idea of ending their life can start to seem like an escape.
And it's not just the illness itself, is it? Certain medications can play a role too.
That's correct. Some medications, like certain heart drugs, corticosteroids, hormone treatments, chemo, even some pain meds, they can actually contribute to depressive symptoms for some people. And it's really important to know that many antidepressants carry what's called a black box warning.
The most serious kind.
Yes, because they have the potential to actually induce or worsen suicidal thoughts in some people, especially when they first start taking them. That's why agencies like the FDA require that warning and mandate careful monitoring when someone starts a new antidepressant.
We also touched on traumatic brain injury. TBI, how does that fit in?
TBI, yeah, any trauma to the head that messes with brain function, it significantly increases the risk of suicide. And other mental health issues too, like self-harm, impulsivity, mood disorders.
And this is a big issue for veterans.
A huge concern, yes. A significant percentage of returning war veterans are estimated to have experienced a TBI. Research also suggests even mild brain injuries earlier in life might increase dementia risk later on. And similarly, you have chronic traumatic encephalopathy, CTE, from repeated concussions in sports.
Right, in football, boxing.
Exactly. Athletes in those high-contact sports are at higher risk for suicide because of CTE.
It's such a complex picture, so many interacting factors. Let's maybe pivot to some of the theories trying to explain why someone might think about suicide.
Okay. Well, early psychological theories offered some initial ideas. Freud, for instance, he saw suicide as sort of this intense aggression turned inwards, rooted in unresolved conflicts with people you both loved and resented. Building on that, Carl Menninger suggested 3 core emotions are often involved: revenge, depression, and guilt, all kind of tangled together.
And then Edwin Schneidman, his work seemed really central. What was his main idea?
Schneidman really focused on this idea of psychoop, just unbearable psychological pain. That combined with feeling totally isolated and seeing death as the only way out.
Psychoop, that's a powerful term.
It is. And he also introduced the concept of subintention suicide. That's where people engage in really risky behaviors, like heavy substance abuse, or refusing essential medical care that are likely to lead to death, but without saying outright, I want to die.
Okay.
And Herbert Hendon, another key figure, built on Schneidman's work, but also really stressed how crucial medication can be for treating severe depression when it comes with suicidal thoughts.
Our sources also broke down risk factors into broader categories. Can you outline those?
Sure. Broadly, you could think about risk factors in 3 buckets: health-related, environmental, and historical. Health factors are things like having other mental health conditions, physical health problems, especially chronic or painful ones, and a history of TBI.
Right.
Environmental factors include things like, well, easy access to lethal means, ongoing stress in relationships, being bullied, losing a job, divorce, being exposed to someone else's suicide.
And historical.
Historical factors are about personal history, like previous suicide attempts, and family history, like suicide in the family, or significant trauma or adversity in childhood.
Okay, shifting from the psychological to the biological, what about neurobiology and genetics? What do we know there?
Yeah, research in neurobiology has flagged a few key brain areas and neurotransmitter systems. For instance, finding consistently low levels of a serotonin byproduct, it's called 5-HIAA, in spinal fluid, that's been linked to increased impulsivity, aggression, and suicide risk.
So low serotonin function seems key.
It seems to be a factor. People who have attempted or died by suicide often show lower overall serotonin activity in the brain. And looking at brain tissue after death, studies have found specific abnormalities in the serotonin system right in the ventral medial prefrontal cortex.
Which is involved in?
Decision-making, emotional regulation. So basically, These findings suggest there might be a link between, let's say, disruptions in brain chemistry and being more vulnerable to suicidal behavior.
And it's not just serotonin, right? The stress response system is involved too.
That's right. The noradrenergic system that's heavily involved in stress response, alertness, arousal that's been linked to suicide risk, too. If that system is chronically overactive, it's often tied to more anxiety, agitation, and, well, a higher risk of suicide.
Okay.
And similarly, the HPA axis, the hypothalamic pituitary adrenal axis, another major player in our stress response.
Yeah.
It tends to be overactive in people with depression and who are at higher risk for suicide. Think of it like the body's main stress alarm.
And it's stuck on high alert.
Kind of, yeah, leading to those feelings of anxiety and distress.
What about genetics? Is there evidence it can run in families?
There is growing evidence for a genetic component. We do see suicide sometimes clustering in families. Now, some of that could be shared environment, trauma, family dynamics.
You're
But researchers do believe genetic factors contribute to vulnerability. And recent brain imaging studies are even starting to identify specific biological markers or phenotypes that seem strongly associated with suicide risk, which further supports that genetic link idea.
Let's focus now on how risk looks different across the lifespan, starting with adolescents and young adults.
Tragically, yes, suicide rates are climbing among 14 to 24-year-olds in the U.S., and the situation is particularly dire for Native American and Alaskan Native youth. They have the highest rate of any youth group in the country.
Why is that? Is it understood?
It's believed to be deeply connected to historical trauma, ongoing inequalities like poverty, poor housing, loss of land, and the erosion of their cultural identity. It really highlights the immense multifaceted pressures these young people face.
It sounds like they need support on so many levels.
Absolutely.
Yeah.
Both mental health support and addressing those wider social issues.
What other risk factors really stand out for this age group?
Well, beyond the general ones, for teens and young adults, you often see things like aggression, disruptive behavior, depression symptoms, feeling really isolated socially.
Okay.
Other things can be running away from home frequently, showing intense rage, family loss or instability, lots of conflict with parents, pulling away from friends and family, talking about death or suicide a lot, struggles with sexual orientation or gender identity, unplanned pregnancy, or feeling like a huge failure, at school or work.
It really underscores the vulnerability there.
It does. It points to needing really holistic support systems.
It's such a heavy load for young people. What about at the other end of the age range, older adults?
Well, the rates used to be much higher, but current stats show suicide as the 17th leading cause of death for people over 65. However, it's important to note the percentage actually goes up for those 75 to 85 and up again for those over 85.
Really? So it increases with advanced age?
Yes. And key risk factors there are things like social isolation, living alone, losing a spouse, financial struggles, poor physical health, and just pervasive feelings of hopelessness. It shows how these challenges can really intensify as people get older.
And it sounds like GPs, primary care doctors, have a really vital role here.
Absolutely crucial. A striking number of older adults who die by suicide actually saw their primary care doctor in the month before, sometimes even the same day.
Wow.
It just highlights how critical it is for those doctors to be able to spot the signs of depression and suicidal thinking in their older patients and get them treatment or a referral. It's a key prevention strategy for this group.
Our sources also mention how culture and religion can kind of shape how we view suicide.
Yeah, definitely. The meaning attached to suicide has traditionally been really tied up with religious beliefs and cultural values. So in Judeo-Christian traditions, for example, life's often seen as sacred, a gift, and taking your own life is considered a sin.
Right.
And cultures that have historically had strong Roman Catholic influence tend to report lower suicide rates.
And conversely.
Conversely, some belief systems, like certain interpretations within Shintoism, which includes reincarnation, might see suicide as, well, an honorable solution in specific situations.
Okay. So given all this complexity we've been talking about, how do professionals actually assess someone's immediate risk, and what kind of help is available?
Well, there's some really useful tools and approaches. One is the Modified SAD Person Scale. It's designed to be a quick, memorable risk assessment tool, often used in places like ERs.
SAD persons, what does that stand for?
It's an acronym. Points are given based on S sex, male, A age, certain age groups, D depression, P previous attempt, E ethanol substance abuse, R rational thinking loss, S social support lacking, O organized plan and no spouse or partner, S sickness, physical illness, and a key modification is adding availability of lethal plan.
Okay, so the score gives an idea of urgency.
Exactly. It helps guide whether someone needs, say, outpatient follow-up, a psychiatric consult, or maybe immediate hospitalization.
And for mental health professionals, there's a more in-depth process.
Yes, the SAFE-T. That stands for Suicide Assessment, Five-Step Evaluation and Triage. It's a widely used guideline.
5 steps. Okay. What are they?
First, identify risk factors specific to that person. Second, identify protective factors, things that might buffer against suicide. Third, conduct a really thorough inquiry about their suicidal thoughts and behaviors. Fourth, determine the overall level of risk. And fifth, document everything, the assessment, the plan.
And this isn't just a one-off check.
No, absolutely not. It should be ongoing, especially if things change for the person, like increased stress or changes in their clinical picture. It's about being systematic and thorough.
What kinds of things are they looking for in each step? Like, what are key risk factors?
Well, under risk factors, they're looking at history of suicidal behavior, any psychiatric disorders, specific symptoms like intense hopelessness or impulsivity, family history of suicide, recent stressors, changes in treatment, and definitely access to lethal means, firearms, medications, etc.
And protective factors.
That's about strengths. Both internal things like someone's coping skills, their religious beliefs maybe,
Right.
and external things like responsibility to family, kids, pets, having good social support.
And the actual suicide inquiry, what does that involve asking?
It gets quite specific, asking about the frequency, intensity, duration of suicidal thoughts. Is there a plan? How detailed is it? What's the method, timing, location? How lethal is the method? Any past behaviors like attempts or even rehearsals? What's their current intent to act? And importantly, how ambivalent are they? Do they have reasons for living too?
Okay.
For kids, you also need info from parents. And sometimes, sadly, you might need to ask about homicidal thoughts too. Based on all that, you determine a risk level low, moderate, high, which then points to the right interventions.
So that could range from hospitalization to safety planning.
Exactly. Hospitalization, outpatient referrals, developing a crisis safety plan collaboratively with the person.
Beyond those formal tools, what about just immediate clues, things someone might say or do?
Yeah, it's so important to be aware of verbal and behavioral clues. Overt statements are pretty direct, like, I can't go on, or I wish I were dead.
Okay.
Covert statements are more veiled, like, it's okay now, everything will be fine, or you won't have to worry about me much longer. Things that might sound reassuring but feel off.
And behaviors.
Big changes can be red flags. Giving away prized possessions, writing farewell notes, putting affairs in order suddenly. Also, big shifts in sleep too much or too little. A sudden, maybe unexpected improvement in mood after being really down.
Oh.
That can sometimes mean they've made a decision.
Oh, right. I've heard that can be a warning sign.
It can be. And also neglecting personal hygiene. Just significant changes from their baseline.
So if you suspect someone's at risk, what are the key things to assess right then and there?
Okay, first, try to get a sense of their current feelings. Depression, hopelessness, anxiety, losing interest. Then, crucially, you have to ask directly about suicidal thoughts. Are you having thoughts of killing yourself?
Just ask point blank.
Yes. It doesn't put the idea in their head. It opens the door. If they say yes, you need to explore frequency, duration, intensity. Then ask about a plan. How specific is it? How lethal is the method? Do they have access to the means right now?
Okay.
You also need to gather the other risk factors, ask about any previous attempts, what was the intent, how lethal was it, were they injured, and then collaboratively work on a safety plan. What can they do instead of acting on thoughts? Who can they call?
Right, making it concrete.
Exactly. And if it's outpatient, you assess their support system. Does their family know? Are there safety resources available?
Our sources mention nursing diagnoses. How do those fit in?
Yeah, using standardized language like ICNP helps. Diagnoses like risk for suicide, attempted suicide, impaired family process, risk for self-destructive behavior. These help nurses structure care plans and communicate clearly with the whole team.
When someone is in a suicidal crisis, what are the goals, both immediate and looking ahead?
Okay, short term, the absolute priority is safety. Stabilize the situation. That might mean getting a friend or family member to stay with them, setting up urgent mental health follow-up, giving them crisis line numbers.
Or hospitalization if needed.
Or hospitalization, yes, voluntary or involuntary if necessary. Long-term goals are about reducing future risk, helping them build better coping skills, improve problem solving, feel less isolated, and get ongoing treatment for any underlying conditions.
What do those interventions look like in practice, say, in a hospital during a crisis?
Inpatient safety is paramount. Following strict protocols, removing potential hazards, keeping detailed records, building rapport through frequent contact, monitoring closely, maybe even one-on-one observation.
Constant observation.
If the risk is high enough, yes. Collaborating on a safety plan they can use after discharge,
Yeah.
and always encouraging them to talk about their feelings, explore alternatives.
And if it's managed outpatient.
Then immediate steps might be arranging for someone supportive to stay with them, making sure weapons or excess pills are removed, encouraging talk, advising against big decisions right now, providing crisis counseling, mobilizing their support network, maybe starting or adjusting meds, but with a limited supply and close follow-up.
After the immediate crisis passes, what does ongoing therapy focus on?
Follow-up therapy often looks at identifying triggers, what sets off those suicidal thoughts, assessing their strengths, and also maybe ineffective coping strategies they're using, working on reframing negative thinking patterns, challenging unrealistic beliefs.
Helping them find hope again.
Exactly, exploring hopes, dreams, goals for the future, reconnecting them with things, people, activities that used to bring them joy.
Sadly, sometimes suicide does happen. The sources talked about postvention. What is that exactly, and why is it so important?
Postvention is the support provided to the survivor's family, friends, colleagues, the community after a suicide. It's critically important and should ideally start fast, within 24 to 72 hours.
Why is the grief different?
The grief after suicide is often incredibly complex, intensely painful. Survivors might face stigma, lack normal social supports, grapple with intense guilt or blame, feel confused, angry. It's a unique kind of bereavement. Understanding potential grief stages, denial, anger, etc. in this context helps. Survivors are also at higher risk for PTSD symptoms.
So the goal of postvention is?
To reduce that immediate trauma and help survivors start grieving in an adaptive way. There are resources out there like toolkits for schools from AFSP and SBRC to guide these efforts.
And it sounds like support needs to extend to the healthcare workers involved too.
Absolutely. Nurses, doctors, therapists involved when a patient dies by suicide can experience significant trauma themselves, even PTSD symptoms. Psychological postmortem assessments are really important.
What does that involve?
The treatment team reviewing the case carefully. What clues might have been missed? Could protocols be improved? It's about learning and improving care. Clear policies on communicating with the family are also vital, usually designating one spokesperson. And documentation, always thorough and timely.
Are there guidelines for the survivors themselves?
Yes, key messages emphasize self-care, allowing themselves to grieve, seeking support, and understanding they aren't responsible for the death. Self-help groups for suicide loss survivors can be incredibly helpful connecting with others who truly understand. AFSP's website is a good place to look for those.
To kind of bring this together, the source material had an example of applying evidence-based practice. Could you walk us through that briefly?
Sure. It described a nurse on a crisis line. A man calls, suicidal, triggered by the anniversary of his father's suicide.
Okay.
So the nurse uses EDP. She considers her experience knowing anniversaries are high risk, understanding survivor guilt, the danger of using alcohol or drugs to cope.
Yeah.
She also considers the research literature, the complex emotions survivors face, the importance of collaboration. And she considers what the patient wants: help, relief from pain. He mentioned being in therapy already.
So what did she do?
She got his info quickly, dispatched a mobile crisis team, and with his permission, called his mental health center to coordinate care. This showed quality improvement, getting help rolling even if the call dropped, and informatics, using info effectively. It hit several QSEN competencies.
That's a great practical example. Okay, this has been a really thorough and, yeah, this one's tough, deep dive. What are the absolute key takeaways you want listeners to hold on to?
I think first, remember, suicide risk is almost always multifactorial. It's complex, rarely one single cause. Things like psychosis, substance use, poor problem solving, impulsivity, low pain tolerance, hopelessness, they can all play a part when someone feels overwhelmed.
Right.
Know the high-risk groups: adolescents, older adults, white males, Native Americans, Alaskan Natives. Identifying recent stressors, precipitating events is crucial. Comprehensive assessment is vital. Verbal clues, behavioral clues, lethality of any plan.
And don't shy away from asking directly.
Never. Asking directly about suicidal thoughts is essential. Tools like the modified SAD person scale can help initially. And remember, there are effective interventions both during and after a crisis. And postvention for survivors is incredibly important.
This really has been a powerful look at such a complex issue, highlighting all those interacting factors. Understanding these nuances, as you said, is just so crucial for support and prevention. We know this is heavy stuff, so thank you for engaging with it.
And maybe a final thought to leave you with. Consider how a deeper understanding of both individual vulnerabilities and those broader societal factors we touched on could lead to more compassionate, more effective help for people at risk. What role can each of us play in building a more supportive, informed community where it's okay to ask for help and where that help is actually available?